ക്ലാസ് അതിലിതിടാൻ പറ്റും.
സ്ലൈഡ് അനങ്ങുന്നില്ല.
തുടങ്ങിയില്ല സ്ലൈഡ് അനങ്ങാന്.
ശരി. ശരി ശരി. സഹസ്രമുണ്ടോ?
രശ്മിയാണ് ഇത്തെ ഗുരു അല്ലേ? രശ്മി?
അതെ സർ. സർ ഞാനാണ്.
അതെ. അപ്പൊ രശ്മി. അപ്പോ പിന്നെ എത്ര പാർട്ടിസിപ്പൻസ് ആയി? 13 പേര്. അപ്പോ പിന്നെ
13 പാർട്ടിസിപ്പൻസ്. റൈറ്റ്. നമ്പർ ഉണ്ടല്ലോ.
തുടങ്ങാനോ? അതെ സാറേ.
എങ്ങനെ തുടങ്ങാം?
ശരി. അപ്പൊ അങ്ങനെ രശ്മി പറഞ്ഞ പോലെ ആരെങ്കിലും പിന്നെ മിനിയോ മറ്റേ എലിസബത്തോ ആരെങ്കിലും വരും എന്ന് പറഞ്ഞിട്ടുണ്ടോ? വരത്തില്ലെന്ന് പറഞ്ഞിട്ടുണ്ടോ? മിനിയ ഇത്തവണ മെസ്സേജ് അയച്ചത്.
മിനി മാഡം എന്തോ മോളുടെ എന്തോ ഫംഗ്ഷനാന്ന് പറഞ്ഞു. മാഡം കെയർ ഇല്ലായിരിക്കും എന്ന് പറഞ്ഞു.
അല്ല സോറി, മിനിയല്ല, മായയാണ്.
അല്ല മിനി മാഡം അല്ല, മായ മാഡം. അതെ,
മായ. മായ. അപ്പൊ മായ കയറാൻ ഇപ്പം എലിസബത്ത് മുമ്പ് അയച്ചുകൊണ്ടിരുന്നത്, ഇത്തവണ മായയാണ് അയച്ചത്. അപ്പൊ അവർ വരത്തില്ലെന്നുണ്ടെങ്കിൽ പ്രോബ്ലി യു ക്യാൻ ബീങ് ആൻ അലൂമിനി, യു ക്യാൻ ഇൻട്രൊഡ്യൂസ് യുവർ സെൽഫ്, ഹു യു ആർ, വാട്ട് യു ആർ, ഹൗ ആർ യു എന്നെല്ലാം പറഞ്ഞിട്ട് പ്രോബ്ലി യു ക്യാൻ ഇൻട്രൊഡ്യൂസ് ദി ശിഷ്യ ഓഫ് ടുഡേ ഓൾസോ, and probably we can start. Last രണ്ട് തവണ എങ്ങനെയാണ് ചെയ്തത്, because the organizers from the other side were not there. So the Guru, on behalf of the RIO Alumni Association, I did the introduction and start. Lang തുടങ്ങാം മതിയോ സാറേ?
അത് തുടങ്ങാം.
And also the slide ഇപ്പൊ പിന്നെ ഫുൾ സ്ക്രീൻ അല്ല സ്ലൈഡ്, പിന്നെ നമ്മുടെ നോർമൽ എഡിറ്റബിൾ മോഡിലാണ് കിടക്കുന്നത്. ഫുൾ സ്ക്രീൻ ആക്കണം. ലക്ഷ്മി പറഞ്ഞിട്ട് നമുക്ക് സ്റ്റാർട്ട് ചെയ്യാം. ലക്ഷ്മി.
ഓക്കെ. ഗുഡ് ഈവനിങ് സർ. ഗുഡ് ഈവനിങ് മഹാദേവൻ സർ. ഫസ്റ്റ് ഓഫ് ഓൾ വെരി ഹാപ്പി ഇങ്ങനെ ഒരു ചാൻസ് എനിക്ക് കിട്ടിയതിന്. ഞാൻ RIOന്ന് പഠിച്ചിറങ്ങിയിട്ട് പിന്നെ അത് കഴിഞ്ഞ് കോർണിയ ഫെലോഷിപ്പ് ചെയ്ത് ഞാനിപ്പം ജനറൽ ഹോസ്പിറ്റലിൽ വർക്ക് ചെയ്യുന്നു, ഹെൽത്ത് സർവീസിൽ. ഇന്ന് പ്രസന്റ് ചെയ്യാൻ പോകുന്നത് കോർണിയൽ അൾസർ എന്ന് പറഞ്ഞ ടോപ്പിക്കാണ്. ഡോക്ടർ പ്രിയങ്ക നായർ ഫ്രം ട്രാവൻകൂർ മെഡിക്കൽ കോളേജ് ആണ്. സോ സർ നമുക്കിപ്പോൾ സ്റ്റാർട്ട് ചെയ്യാം.
Yes, we will start.
Case presentation. Dr. Priyanka Nair, first year PG. Presenting the case of Presenting the case of Rajamma Amma, 72 years old, female, hailing from Kollam, who is a daily wage laborer. Presenting complaints was defective vision in right eye since 1 year, foreign body sensation and watering in the right eye since 3 months, redness and photophobia in the right eye since 7 days. History of presenting illness. Patient was apparently normal 1 year back, following which she developed defective vision in right eye, which was painless and gradually progressive in nature, for which she gives history of undergoing laser treatment, even after which she did not experience any improvement in vision. It was associated with foreign body sensation and watering in the right eye since 3 months. 7 days back, she developed redness and photophobia in the right eye. Redness was gradually increasing in intensity. It was associated with pain, which was throbbing in nature, with no aggravating or relieving factors. Since symptoms worsened, she visited a local hospital and was started on topical medications. Since she did not get any symptomatic relief, she consulted our hospital. No history of foreign body fall, ocular trauma, or injury with vegetative matter. No history of colored halos, vomiting, or headache. No history of flashes or floaters. No history of use of contact lens or bathing in the pool. No history of joint pains. No history of similar complaints in the other eye. Past history. No history of similar complaints in the past. History of cataract surgery in right eye 4 years back, following which she had good vision improvement for 3 years. History of gradually progressive painless defective vision in right eye 1 year back, for which she underwent laser treatment in December 2023. No improvement in vision was noticed after laser treatment. History of cataract surgery in left eye 2 years back, following which she has good improvement in vision. No history of diabetes mellitus, bronchial asthma, or any other systemic illness. Family history, no relevant family history. Personal history, non-veg diet, normal appetite, no history of weight loss, disturbed sleep since 2 weeks, no alteration in bowel or bladder habits, no addictions. Drug history, patient was on topical medications in right eye, which included atropine, natamycin, moxifloxacin, and tobramycin since 1 week. No history of chronic use of topical drops or over-the-counter drugs in both eyes. No history of drug allergy. General physical examination, patient is conscious and cooperative. well oriented to time, place, and person, moderately built and nourished, no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or bilateral pedal edema. Vitals, pulse 74 beats per minute, normal rhythm, volume, character, condition of vessel wall. Blood pressure 110/70 millimeters of mercury, measured in the right arm in sitting position. Temperature, patient was afebrile. Respiratory rate 14 per minute. Systemic examination, CVS S1 S2 heard, no murmurs. Respiratory system, normal vesicular breath sounds heard bilaterally. Air entry bilaterally equal, no added sounds. GIT per abdomen was soft, non-tender, no organomegaly, bowel sounds present. CNS, higher mental functions normal, no focal neurological deficit. Ocular examination, head posture was normal, no facial asymmetry, eyes orthophoric, no ptosis, proptosis, or nystagmus. Extraocular movements, ductions, vergence, and versions, full in all directions of gaze. Right eye, visual acuity, right eye, hand movements were seen with a distant vision with projection of light accurate in all quadrants. In the left eye, distant vision was 6/6 blurred. Near vision in the right eye could not be assessed. Left eye with an addition of +3 diopter sphere, patient could had a near vision of N6. Color vision could not be assessed in the right eye. In the left, it was normal. Field of vision by confrontation could not be assessed in the right eye, full in all directions in the left eye. Now the right eye, the affected eye. Periorbital area was normal. Eyeball was normal. Lids, diffuse upper and lower lid edema present. Mebomitis was present. Lower lid ectropion present. No tracheasis. Lacrimal apparatus. Lacrimal gland area normal. Lacrimal sac area normal. Punctum normal. Regurgitation test negative. Eyeball normal. Conjunctiva, circumcorneal congestion was C+. Conjunctival congestion C. Mild chemosis. Upper tarsal conjunctiva showed no evidence of foreign body. Sclera was normal. Tear film could not be assessed due to corneal lesion. Cornea, a 4 into 5 mm dry looking stromal infiltrate with feathery margins extending up to mid-stromal level, involving the paracentral area towards the infratemporal aspect of the cornea.
Priyanka, can you show me the picture of the ulcer while you present this?
Yes, ma'am.
Okay, now please present.
Okay, a 4 into 5 mm dry looking stromal infiltrate with feathery margins was seen extending up to the mid-stromal level, was seen in the paracentral area towards the infratemporal aspect, extending from 7 o'clock to 9 o'clock position with surrounding corneal edema. There was diffuse corneal edema and scattered microbullae throughout the cornea. Then no satellite lesions, pigmentations, immune ring was present. Then corneal sensations were normal. Then anterior chamber, Van Herrick's grade. Ma'am? Anterior chamber, Van Herrick's grade 4, no hypopion. Diagram. Iris. Other visualized iris areas showed atrophic changes. Other details were hazy. Lens PCIOL in situ. Pupil was round 4 mm. Direct light reflex and consensual light reflex absent, suggestive of pharmacologically dilated pupil. IOP measured by non-contact tonometry was 16 millimeters of mercury. Then fundus, media hazy due to corneal lesion, hence further details could not be seen. Left eye, periorbital area was normal, eyeball was normal, lid showed mebomitis, lacrimal apparatus, lacrimal gland area normal, lacrimal sac area normal, punctum normal, regurgitation test negative. Eyeball was normal, conjunctiva normal, sclera was normal, tear film, tear meniscus height 1 mm, T-bud 14 seconds, and Schirmer 1 and 2 were done. Cornea was normal, it showed no bullae or guttae, and anterior chamber, Van Herrick's grade 4. Iris, normal color and pattern, PCIOL was seen. Pupil, round, 3 mm, direct light reflex and consensual light reflex with risk. IOP by NCT was 14. Fundus, media clear. CDR was 0.4. Disc and vessel seen. Macula was within normal limits. FR was present. Background retina was within normal limits. Summary: 72-year-old female with no known comorbidities presented with complaints of foreign body sensation, pain, watering, photophobia, and defective vision in right eye. History of cataract surgery, both eye, one following which patient had defective vision in the right eye since 1 year. History of laser treatment in right eye before 6 months in view of defective vision. On ocular examination, visual acuity of hand movements with accurate projection of light in all quadrants was obtained in the right eye. Circumcorneal congestion, conjunctival congestion, and diffuse edema of both eyelids of the right eye was noted. A 4 into mm size stromal infiltrate extending up to the mid-stromal level involving the paracentral area towards the infratemporal aspect of cornea from 7 o'clock to 9 o'clock, around 2 mm away from the limbus, with surrounding diffuse corneal edema was seen. Scattered microbullae was seen. Descending membrane folds were seen. Fundus, right eye, media hazy due to corneal lesion. Left eye fundus was within normal limits. Provisional diagnosis: infective keratitis right eye, clinically fungal. Pseudophakic bullous keratopathy right eye. Pseudophakia both eye. Lower lid ectropia on right eye.
Okay,
What is,
so
what is the differential diagnosis here?
Um,
Infective keratitis, clinically fungal, you said. Why fungal? Was there a history of prolonged treatment and still not getting cured?
She was her symptoms were much less than the signs that we could see. Like she was not that symptomatic when she came. So she was giving a prolonged history of 2 to 3 months where she's having this foreign body sensation. And also the appearance of it was a dry looking. The photo doesn't, the slit lamp photo doesn't show justice, but it was dry looking and also feathery margins. So that's why.
What is the corneal sensitivity like?
In the area that was spared from the lesion, the corneal sensations were normal.
Madhen sare, Madhen sare, ഇന്നത്തെ ഗുരുവിന് ക്വസ്റ്റ്യൻ ചോദിക്കാനുള്ള പ്രൈമറി ചാൻസ് കൊടുക്കണം.
ഓ അങ്ങനെയുണ്ട്. സോറി സാറേ, കുറെ നാളായി കേറിയിട്ട്.
നമ്മളെപ്പോഴും മറ്റേ പ്രൈമറി ഗുരുവിനെ പ്രൈമറി ഗുരു gets the first chance. പിന്നെ സമയമുള്ളതനുസരിച്ച് other faculty who come in, സമയമുള്ളതനുസരിച്ചവർക്ക് അതിനാണ് നമ്മൾ ഇന്നത്തെ ഒരു പ്രൈമറി ഗുരുവിനെ നമ്മൾ ഡിസൈഡ് ചെയ്യുന്നത്.
പറഞ്ഞത് നന്നായി.
സർ ഞാൻ ഓക്കെ. സോ പ്രിയങ്ക ഫസ്റ്റ് സ്ലൈഡ് മുതലൊന്ന് ഇടാമോ? ഫസ്റ്റ് സ്ലൈഡ്
എവിടെ നിൽക്കുന്നു?
ഫസ്റ്റ് സ്ലൈഡ്. സോ
കോളേജിന്റെ ഗേറ്റിന്റെ അവിടെ കൂടെ വന്ന് ഒരു ചെറിയ മുടുക്കുണ്ട്.
സോ ഫസ്റ്റ് സ്ലൈഡ്
അതിനിടയിൽ കൂടെ വന്നാൽ മതി.
This one, ma'am?
First slide. It okay. Okay. So, any risk factors in this slide that you see for a corneal ulcer?
Daily wage.
സുശീല വന്നിട്ടുണ്ട്. ഞാൻ താഴോട്ടൊന്ന് പോയിട്ട് വരാം. കെ സുശീല.
Daily wage, and any agricultural related to any agricultural.
So, in other words, what professions are the risk factors for corneal ulcer?
People involved. Agricultural workers, ma'am.
Yes. Agriculture workers will lead to which type of ulcer?
Fungal keratitis.
No.
Because vegetative matter, any corneal abrasion that can come because of a vegetative matter or animal things like that. It is a risk factor for fungal ulcer.
Okay. What about soil?
Contaminated soil, again with acanthamoeba, that can also be a risk factor.
Acanthamoeba is not a very common protozoal. It's very difficult to find also. So should acanthamoeba be the first diagnosis? Should be something else. What others can come from for soil?
Fungal, madam?
Soil, what else does it predispose to? Soil.
Ba-
It's usually bacterial, okay? Bacterial things that usually come from soil. Okay, next slide. So I think we'll go through slide by slide and just tell you how to get to a diagnosis of a corneal ulcer. We'll come to the diagnosis later, but
Okay.
how you should approach a case of corneal ulcer.
Okay.
So here you have said a defective vision of right eye into 1 year. The patient has defective vision. And then you have foreign body sensation, watering, redness, photophobia. Okay, I think so. More specific for a corneal ulcer over here is redness. So on the base of redness, what change in, I mean, how can you find out an ulcer? By what classify the ulcer on the base of redness? There is a whole point in taking the history and taking your findings is to clinically come to a diagnosis of whether it is a fungal or a bacterial. That's the whole point, because we won't get a scraping result, not always very sensitive, and culture reports we have to take 3 days. So the first clinical our clinical approach to the case is very important. So the history also helps towards it. അതാണ് നമ്മൾ ഈ ഒരു കേസ് വെച്ച് നമ്മൾ ഉദ്ദേശിക്കുന്നത്.
Okay.
But in this case, there's a redness. So anything in redness that you will ask more?
Sir, we'll look examining or we'll asking the patient, madam?
Examining also.
Examining, if there is a like differentiate between circumcorneal congestion and diffuse conjunctival congestion.
You will find what kind of congestion in corneal ulcer?
Circumcorneal congestion will be
Definitely. So there is no doubt in that. So what difference in a circumcorneal congestion in between a bacterial and a fungal, which is more very it is highly red and the lids are all edematous, which is the one that has more of the symptoms?
Symptoms will be more in bacterial.
Yes, it will be in bacterial ulcer. And I'm not sure if you're supposed to mention in presenting complaints as photophobia. I don't know. പണ്ടൊക്കെ നമ്മളോട് പറയും photophobia എന്ന് പറയാൻ പാടില്ല. It's only just a difficulty in looking into the light എന്നേ പറയാവുള്ളൂ എന്ന് പറയും. Okay, so I'm not sure whether you should put that. Okay, the next slide.
Yeah.
So in this, the one point that I felt that you should have mentioned in the history of presenting illness is this patient is having a defective vision since 1 year. But over the past 7 days, she has developed additional symptoms of redness and pain. But you have not mentioned whether the defective vision has progressed over the last one week or it has become, it is static. That is, there is no change in the vision over the past 1 week. So does it make any, does it help you in any way?
Yes, because the defective vision had worsened because mostly because of the stromal edema.
So has it worsened? That's what my question is.
It was worse. It had worsened, madam.
It has worsened. Okay.
Yeah,
so she had a defective vision of the past 1 year, but did she have any useful vision in that eye?
Did she have any?
Useful vision in that eye, in the right eye?
No, madam.
She did not have any useful vision in the right eye, but she felt it's worsened over the past year. So I think that you should have mentioned over here that it was gradually progressive. And you have described the defective vision 1 year back, but you have not described what has happened over the last 1 week. That is important. Okay. I'll tell you why it is important later. Okay. Then in addition to that, I think so you have mentioned all the negative histories, but you did not mention one important negative history. Was there any discharge in this case?
No, yes, she did have discharge.
You did not mention that.
Yes.
So how can discharge help us to differentiate between the different ulcers?
In the case of, if it was a bacterial, in the case of Pseudomonas ulcer, we would have got a mucopurulent green colored ulcer, discharge. Then also in acanthamoeba also the discharge would have been, the discharge is more. Then if discharge we can.
Okay. Or rather, when do you get a mucopurulent discharge? Which organisms cause a mucopurulent discharge?
Pseudomonas, madam.
Yes, one is Pseudomonas. It is greenish
Okay.
color and but it will
Okay.
be a mucopurulent. The thing is that when you try to lift the discharge, you'll see like it makes a tag like thing. And as soon as you clean it, you come back and see the patient after five minutes. Again, there's a discharge. So what is the reason why if there's so much discharge in Pseudomonas?
Because the progression is very fast in the case of
Yeah, so or rather it is a virulence of the organism that is shown by the discharge. So the discharge being mucopurulent and so profuse is because the organism is very virulent.
Okay.
So can you describe the progress of a Pseudomonas ulcer?
Okay. At first, it start within.
Or rather, why you should have a clinical acumen. The best example is a Pseudomonas ulcer.
Okay. First, the patient when a Pseudomonas ulcer will present as it is a very virulent organism. So the defect, and then there will be a very dense infiltrate, and the remaining cornea will also show a semi-opaque, like that will be a ground glass appearance of the remaining cornea. Also, there will be a dense stromal, there will be stromal edema, and there will be an anterior chamber reaction also, mostly with the hyperpion. Mostly, and within it can also perforate within 48 hours if not attended to.
So when you are asked about Pseudomonas ulcer, the point that they are looking for you is mention the word corneal melting. So
Okay.
Pseudomonas is a case where there is rapid progression and the cornea melts like anything, and within a period of how many days?
Seven.
I'm just trying to trick you. So I asked you how many days?
48.
48 days on.
No. Don't know.
It's usually within 18 to 24 hours. You won't even get 1 day if you have a Pseudomonas ulcer. So that important is you see a case of Pseudomonas ulcer, you should immediately start the specific drugs for Pseudomonas. You don't get time for scraping or culture reports to come. It is your clinical suspicion that this is a Pseudomonas ulcer. It's just a suspicion. This is a Pseudomonas ulcer. And you immediately start the treatment for Pseudomonas. So what is the treatment for a Pseudomonas ulcer?
Fortified antibiotics.
Which fortified antibiotic will you start?
Cephalosporin, madam. Fortified cephalosporin.
For Pseudomonas? Is cephalosporin effective against Pseudomonas?
No.
So which cephalosporin is effective against Pseudomonas?
Third generation.
You won't tell me that. I am not very sure about the generation, but it is very specific, no?
Ceftazidime.
Yes, fortified ceftazidime is what you have to start for Pseudomonas. Okay, so that is how you should approach a case. See, from the discharge itself, you will be able to get the suspicion that this is an extremely large ulcer. You won't get time to form a hyperpine. Don't say there's a hyperpine in Pseudomonas. There won't be any time for hyperpine to form in Pseudomonas because the anterior chamber will immediately melt.
Okay.
So you won't get time to form a hyperpine, which is the characteristic hyperpine ulcer. So you made a mistake, so I'll go ask like that. Which is the case when you get a hyperpine ulcer?
Streptococcus pneumoniae, ulcer serpens.
Yes. Then?
Then fungal ulcers.
Yes, fungal ulcers. Yes. So streptococcus or pneumococcal ulcers, they are characteristic known as what?
Ulcer serpens.
Ulcer serpens. It is also otherwise known as a hypopyon corneal ulcer. It is given like that, though hypopyon can form in other cases like fungal keratitis. So how will you differentiate a hypopyon in a pneumococcal ulcer and a fungal ulcer?
It will be immobile in the case of a fungal ulcer, and
why?
It will be because of the exudates. The hyphae has been penetrating, so it will be more the exudates.
So how do you know if it's a mobile or an immobile hypopyon?
Position, madam, head position.
How will you position the head?
I don't know. So lie down.
Correct.
Make the patient lie down and then turn to
you will ask the patient to lie down straight up
and then turn to the so when the patient turns, we will see it if it's mobile with the dependent position.
So for example, I am asking the patient to lie down straight up, and after 1 minute I bring the patient and look in the slit lamp. Will it be mobile?
No, madam.
So how will you ask the patient to lie down?
Ask the patient to lie down first, and then turn that to one side. We can see mobility.
Okay, you turn to one side and wait for how much time?
1 minute.
It's usually 5 to 10 minutes. Okay, 10 minutes, I think so. 10 minutes, and then you go and look at the slit lamp. So if it is a fungal ulcer, the change of the hyperpine would not have changed. But if it is a bacterial, it would have changed. So that is how on the basis of hyperpine. So we really diverted from the topic. So anyway, discharge, on the basis of discharge, there are virulent organisms. That one is Pseudomonas, the other virulent organisms are gonococcal ulcers. Gonococcal, we don't have cases now. That's why we won't find it. Gonococcal ulcers can also profuse discharge, might be there. Okay. Then you said acanthamoeba. Acanthamoeba is now, it has got, it presents like any ulcer. Any can present it's a huge range. So I don't think acanthamoeba you should say in this thing.
Okay.
In a hyperpine, it has got so many presentations. Okay. Okay. Now coming on to all the negative histories that you asked. So you have asked for a history of foreign body fall, ocular trauma. That is a very good negative history. Why have you asked for a colored halos, vomiting, and headache?
Acute,
especially in this case, why have you asked?
Redness is present, and a blurred vision, patient is saying, and also an acute angle closure glaucoma.
A blurred vision of 1 year, 1 year's duration, you are thinking of an angle closure glaucoma?
No, madam, with redness and vomiting, headache with that.
Okay. Okay, you thought of a glaucoma, but definitely it's not angle closure glaucoma. It should have been some other glaucoma that you have. Okay. Or rather, I will put it like this. See, this patient has got a defective vision of 1 year. She has undergone some laser treatment. You don't have a fundus view.
Okay.
And this patient is, you are asking a leading question. Do you have a colored halos, vomiting, headache? And you have a cornea that is edematous, the entire cornea is edematous that you said. So are you looking for any specific glaucomas in this case?
Yes.
Did you look for any specific signs or any specific glaucoma that might have arisen? Did you think why the laser was done? Was it a PI or was it some retinal laser? You could have asked that actually. Priyanka?
For PCO, madam, because PCO, yeah.
Okay, so you thought, okay, it could have been a PCO, but any other laser in that is a glaucoma that have been a glaucoma that could present in this case, you could have thought like that. Which glaucoma could have presented in this patient?
Yes.
I think so. Priyanka is a first year, so I think so it's really too much for her to answer that question. But I think so a better way would have been you should have looked for a neovascular glaucoma because a laser treatment 1 year back, it could have been a retinal problem. Then she has continuously had the defective vision of the 1 year that is not improved after the laser treatment. And now you're thinking of glaucoma. It's good, but you should also be able to answer why you thought of a glaucoma in this situation. Because your possibility was neovascular glaucoma. Okay.
Okay.
And then you have asked for flashes and floaters. Any particular reason you asked that?
PVD, madam.
So why is it important in a corneal ulcer case?
No, not important.
Not important. Okay. So don't say such things. Then next one.
History of use of contact lens, acanthamoeba. Then,
so again, your very favorite organism is acanthamoeba. So which is the most common organism that occurs in a contact lens use?
Pseudomonas.
Yes. So you should say that no first. Why are you saying acanthamoeba?
Pseudomonas.
So it should have been Pseudomonas. Okay. So in contact lens infections, can you know the different types of contact lens?
Rigid.
Rigid?
Rigid contact lens.
Yes. Yes, soft contact lens.
Contact lens. That hard contact lens.
Which contact lens? That is soft lens lano, ado rigid lens lano, infections varan kudal sadhyada.
Rigid, madam.
Why?
Because that like the oxygen that supply is completely it is not.
What is a rigid contact lens full name? What is it called? It's rigid. Baki in the rigid. RGP. So what does GP stands for?
Glass, rigid glass.
No. Rigid gas permeable. So the word itself says it is really permeable to gas, isn't it? So you don't have to worry about that much rigid gas permeable. Or rather, soft contact lens lana corneal infections rather than a rigid gas permeable. And in soft lenses itself, you have different types of contact lenses. You have extended wear, you have daily wear. So among them, it is an extended wear. That is the one that we use for nearly 8 to 10 hours has got a more predisposition to cause contact lens. Now, the different types of organisms that can occur in contact lens, almost everything, especially the anaerobic bacteria, can cause contact lens infections, but the most common is Pseudomonas. Okay, most common is Pseudomonas. After that comes staph, and then only comes Acanthamoeba. But Acanthamoeba as such is not because of the contact lens, but rather because of improper cleaning of the contact lens. That is when you clean it in tap water and all. That is actually which causes the Acanthamoeba infections. Okay. And the next leading question that you asked was, did he bath in pools? Why did you ask that? That is for?
That is for
Yes, that is for Acanthamoeba. It's specific for Acanthamoeba. Okay. So that is it. Now you asked for no history of joint pains. Why joint pains?
Connective tissue disorders like rheumatoid arthritis can produce peripheral ulcerative ulcer.
Okay, you asked this because it is a peripheral ulcer?
Parasite, no.
Towards the inferior, madam. Okay, so that is why you thought of that. Then next is no history of similar complaints in the other eye. Do you expect any similar complaints in the other eye in this case?
Similar complaints, again, it is pseudophakic eye. So if any rupture of bulle, if there is, I didn't see any bulle in that eye, but if there was any complaint, like that is also a pseudophakic eye. So
okay, good. You thought like the other eye might have pseudophakic bullous keratoconus. Or even if it is in a case of PUK, if you're presenting a case of peripheral ulcerative keratitis, this would have been a very good leading question because you want to know whether the other eye has got similar lesions. So that means it's good. You're thinking ahead. Okay, so the next slide. Okay, I think so. So which systemic illnesses are usually predisposed to corneal ulcers?
connective. If there, I asked it in the, my point was if there is any patient is having any malignancy and is undergoing any chemotherapy or thing like that. So in an immunosuppressed state.
Okay, you thought of it, but still, which is the most common risk factor you would ask in a corneal ulcer? You would ask. You've asked it right over here.
Diabetes.
Yes, diabetes. Why do you want to know whether
it is the most, it'll result in a non-healing ulcer in most cases. The healing process will be delayed.
Okay. The healing process will be delayed, and also because in diabetic neuropathies, the sensations would be decreased. So probably these patients will have not neurotrophic. Foreign bodies may fall and they may not realize that. Okay, so that might be the reason you have asked for diabetes. Okay, next. Okay, in this thing, I wanted to, I mean, there was not much to be asked. You have asked about addictions, definitely. Which addiction in particular you would have asked if it's a male patient?
Smoking.
Yes, smoking is more important because it causes a lot of non-healing ulcers. Smoking can predispose to that. But why did you ask for no history of weight loss? Why specifically you asked for that? Because we usually don't put that in a personal history, but you have asked no history of weight loss.
Malignancy or TB. History.
So is malignancy or tuberculosis pertinent to this corneal ulcer? TB causing a corneal ulcer is, I don't know. Have you seen a case of you get mycobacterium? They're acid-fast mycobacterium, but it is very unlikely ulcer. You don't have to ask such questions. Rather, don't ask any unnecessary leading questions that can become uncomfortable for you. So, no history of weight loss, you don't have to ask. You make the patient or choice, but if it's not significant, don't put it inside your history. Okay, you will simply get questions like this. Okay, next. Okay, so you have asked about a drug history. So, how is a drug history important in case of a patient with a corneal ulcer?
Chronic use of any steroids, madam? Like patient has been using any steroids for
Okay,
a long
so if you use steroids for a long time, what will happen?
the normal
Yes.
simple.
Yeah, the normal flora would have been altered, and so it predisposes to infections. Even our lids have got a lot of bacteria, so even that can cause infection. So that is why you wanted to think about a topical steroid. So any other reason why you want to ask chronic use of drops?
RIO still.
Yeah, anti-glaucoma medications, again, say the chronic thing, because again, I said a glaucoma history, that may be pertinent. History wise, glaucoma important. So you could have asked like glaucoma history and but what I meant is when you are using a long time, one is steroids, another is anti-glaucoma medications, another is any drop. Okay, any drop when you have, if the patient is using it, you maybe it's not hygienic. It can itself act as a nidus for a lot of organs and to grow in the drop. They might not have used it properly. ചിലപ്പോൾ ഉണ്ടല്ലോ ചെറിയൊരു ചുമപ്പ് വരുമ്പോൾ ഒരു വർഷം മുന്നേ കയ്യിലിരിക്കുന്ന ഏതെങ്കിലും ഡ്രോപ്സ് എടുത്ത് അവര് വെറുതെ ഒന്ന് ഇട്ട് നോക്കാന്ന് പറയുന്ന ആൾക്കാരുണ്ട്. This is a very common practices. So that also could have been the reason for the corneal ulcer. So that is why we should use the patient whether there's any chronic use of topical drugs.
Okay.
So that's good. Okay. Now, next. Okay, and we'll go to the next. Skip the next. We'll come to the main examination. Next. Oh, wait. Next slide. Okay, here. In this slide, what are the risk factors that you are, if you are presenting a case of corneal ulcer, in each area, can you tell me what all things you will look for as a clinician? There is a periorbital area, എന്തൊക്കെ നോക്കിയിരിക്കണം ഇതില് എന്തൊക്കെ നോക്കിയിട്ടുണ്ട്, ഐബോൾ എന്തൊക്കെ നോക്കിയിട്ടുണ്ട്, ലിഡ്സിൽ എന്ത് നോക്കിയിട്ടുണ്ട്, ലാക്രിമൽ അപ്പാറ്റസിൽ എന്ത് നോക്കിയിട്ടുണ്ടെന്ന് ഓരോന്നൊന്ന് എടുത്ത് പറയാം.
Okay.
Not in this question. In this case, I'm saying what all would have you looked for?
Okay. First, the lids specifically, because if there's any ectropion, because that itself can result in not.
You'll only look for an ectropion?
No, trichiasis, misdirected cilia, that is trichiasis.
Okay, so tell me how each of this can affect, and how an entropion can affect, how an ectropion can affect. Both of this you should tell me.
Okay. Entropion, so there is an inward rolling. So definitely the eyelashes will rub against the cornea, and that can be one cause. And
yes, it will rub against the cornea
and will cause multiple erosions, corneal.
Yes, it causes erosions, and that itself can predispose to a later infection. Okay.
Then in the case of ectropion, there's outward rolling. So definitely there won't be an adequate closure. So that itself can result in exposure keratitis, like too much of, like it's not closed, so exposure keratitis. Then coming just...
ectropion need not always cause an exposure keratitis, or rather you're trying to say something else. Lag of thanos will cause an exposure keratopathy.
Puncture is... I don't know if it's right, but because there is an ectropion, the puncture is more prone.
You're correct. You're coming to that. Yes.
More prone to infection. Like
okay, you're thinking of a canaliclitis. Good.
Puncture,
probably the patient is watering and he's rubbing it, so you can expect something in the canalicular region. So canaliclitis can cause. So which organism is canaliclitis leading to a corneal ulcer? Which organism?
Actinomyces.
Yes, good. So actinomycosis causes canaliculitis. So close to that, there is another one thing.
Puncture. Like.
No, lacrimal sac. So lacrimal sac infections, dactylocystitis cause predisposed to which infection?
Streptococcus pneumoniae.
Yes, pneumococcal ulcers. Good. So we'll come back to the first answer. So an ectropion causes an outrolling of the puncta. And so what gets disturbed?
The tear
Yes.
film.
The tear meniscus gets disturbed, and a dysfunctional tear film will lead to infections. How? What are the natural defense mechanisms of the cornea?
They have the epithelium, the epithelial layer, the superficial cells have some microvilli, which has this glycocalyx. So that keeps it in a relatively dehydrated state by connecting with the mucus layer of the tear film.
Okay, so you mean that if there is any foreign bodies, it might slightly be brushed away. Okay.
Then the homogeneity, like the epithelium and tear film, the refractive homogeneity also maintains, keeps the.
What are the natural defense mechanisms of the eye in the lids? The lids. Okay, the lids. You have the lids, you have the blink reflex. The lids itself, it like a lot of dust will collect on your eyelashes. So a lot of things don't come into the eye. The second thing is a blink reflex. The blink reflex, you have a normal blink reflex. The thing is that whatever falls is each time they are wiped off from the corneal surface. There's one thing. The next thing is that you have the tear film. So the tear film is there. It has got a lot of organisms, and you have a lot of antibacterial properties in the tear film. And so a proper tear film itself on the surface of the cornea helps to give it an antibacterial property. Okay. Then you have in the lids, in the eyelashes, a lot of saprophytic bacteria, which will prevent from other organisms colonizing. So that is another thing. Okay. So these are the natural defense mechanisms of the eye. So the other one is, how do you maintain the corneal detergescence? That's what you tried to say, that the epithelium being, there's a microvilli, there are hemidesmosomes in between the superficial cells. So because of that, the water doesn't get inside the cornea. But rather the natural defense mechanism of this. So in this case, a lower lid ectropion. So this is a one major risk factor over here that you have in this case. So probably when you present this case, you have to like എന്നോട് ഇപ്പൊ ചോദിച്ചാൽ എക്ട്രോപ്പിയുടെ ഗ്രേഡിങ് എനിക്കറിയില്ല പക്ഷേ എക്ട്രോപ്പിയോൺ ഗ്രേഡ് ചെയ്യണം എന്നാണ് എനിക്ക് തോന്നുന്നത് in this case because ectropion you have mentioned in ectropion you should have graded the ectropion over here okay because that's a major risk factor okay and also if you say ectropion and you think of exposure keratopathy then you should have mentioned the Bell's the Bell's reflex that is whether it is good or fair or it is poor adu parthirikku but ectropion does not cause exposure keratopathy because there's no lag of thymus ഉണ്ടെങ്കിൽ മാത്രമല്ലേ അത് വരുള്ളൂ okay then what else any other risk factor that you have mentioned in the lids
Meibomitis.
Yes, meibomitis. So meibomitis predisposes to which infection in the cornea?
Staphylo.
Okay, staph and with Moraxella catarrhalis. Okay, Moraxella catarrhalis is another corneal infection that can occur. So how can you tell me that this is not a Moraxella catarrhalis infection, or rather it's not a marginal keratitis? If I tell you that this is a case of marginal keratitis, what are the features against that?
Mostly it is seen as a chronic state. Moraxella is a chronic state.
So, or rather, what are the clinical features of the marginal keratitis?
Indolent ulcer.
They are usually pinpoint ulcers that occur at, it is right. You know that the inciting factors in the lids is because of the meibomitis. So it comes in parts where the lid is in close contact with the cornea. That is, it comes in the 2 o'clock, that is right. In the top, you have the 2 o'clock position and the 8 o'clock position. And then in the bottom, you have the 4 o'clock position and the top you have the 2 and 10 and bottom you have the 4 and the 8 o'clock position. So these are the positions where usually you get a marginal keratitis and you would definitely have, it starts right at the limbus. You won't have a clear zone. Okay, here you have a clear zone, and then you'll have a lot of vascularization. And like you said, it's an indolent ulcer, chronic ulcer. So a waxing and waning course, the patient will give recurrent, the history of recurrent redness and pain since many years. Another thing, it's there in both eyes. Meibomitis is there in both eyes. So it would have a bilateral presentation. So these are the things that you have to say if you are asked like this, whether this is a marginal keratitis. Then you did not mention anything of the upper tarsal conductor, or have you mentioned it later?
Yes, madam. Here.
You've mentioned it later. Okay, then okay. Next thing, lacrimal sac. Okay, I think so. We have covered those topics. The next thing, eyeball conjunctiva. You have a circumpolar condition, mild chemosis. So you mentioned chemosis here. So chemosis, quite unlikely in this case. Chemosis, why? Chemosis, they are very virulent ulcers cause chemosis. So any particular organisms that can cause chemosis?
Nocardia.
Nocardia. Nocardia is an indolent ulcer. It's a very, very, very slow moving ulcer.
Madam, Pseudomonas. I don't know, madam.
Okay, Pseudomonas. Okay, Pseudomonas. You can say gonococcal ulcers. Again, mucopurulent ulcers. They're very virulent. That conjunctiva it reacts so badly. That is what usually causes a chemosis. Okay, so I don't think so. This would have a chemosis. You really had a chemosis in this?
I saw it when the patient had come the first day, madam.
Okay, okay. You mentioned the upper tarsal conjunctiva, but the ulcer is in the inferior. You didn't mention anything about the lower tarsal conjunctiva. Why? The ulcer is inferior.
Yes, ma'am.
You didn't mention the lower tarsal conjunctiva. Why?
Sure. Right.
Should mention both tarsal conjunctivas. You should look through both of them, an upper tarsal conjunctiva and the lower tarsal conjunctiva. You should look for them. Okay. For any missed foreign bodies, that is what you want. Okay. The next is sclera. You said normal. So sclera in a case of corneal ulcer, can it be involved?
I read that sometimes in fungal ulcers, scleritis can get.
Yes. Yeah, not in just fungal ulcers. You have it in Pseudomonas. Again, Pseudomonas is a very virulent ulcer. So the cornea തിന്ന് കഴിയുമ്പോഴത്തേന് അതിന് സ്ക്ലീറയും തിന്നാൻ തോന്നും, വിട്രീസ് തിന്നാൻ തോന്നും, അത് എല്ലായിടത്തും വരും. So it melts like that. So scleritis usually occurs in Pseudomonas ulcers. In this thing, even in acanthamoeba also you can get scleritis.
Okay.
So that is why. So you have to look ഇതിൻ്റെ അകത്ത് എഴുതിയെങ്കിലും any ulcer you should look specifically for a sclera, because you often missed these things. Okay. And you have mentioned about the tear film. Very good. Okay, next. Okay, I think so. We'll go to the diagram. So can you have you by-hearted how to present this ulcer?
No, I will say, madam. It's okay.
Okay, usually in MS exam, sometimes they'll take your papers. You'll have to present it. You should learn to present a corneal ulcer without seeing the notes, okay? So you're in your first year, you have a long way to go, so that's okay. But again, some points missed over here is that in an ulcer, can you show me your written material?
Yeah, sure.
Okay, you're written a 4 into 5 mm dry looking irregular shaped corneal infiltrate with feathery margins extending up to the mid-stromal level involving the paracentral area. Is the center part of the cornea affected?
In this pic is the central part was not involved when it came, actually. That is why I didn't mention it. But it was involved, I mean, not completely, but part of it was involved.
So I think so if it is a central part is involved, I think you should not say it's a paracentral thing, because if the center is involved, that is so important for us because it will affect the vision. So you can rather say that it is a paracentral ulcer which is extending towards the center, at least towards the pupillary axis. Pupillary axis involved ചെയ്യുന്നുണ്ടോ എന്നുള്ളത് അത് അവിടെ clear cut ആയിരിക്കണം. Whether it's involved in the pupil, it is the examiner, what picture you are giving here is a paracentral ulcer. So you're thinking probably an inferior ulcer is a PUK present. But this you are thinking of a fungal keratitis. Fungal ulcers, they occur where usually? What is the site of fungal ulcers?
Central.
Yeah, they are central ulcers. They're central ulcers. So you're thinking clinically fungal and you have written here paracentral, and it looks like a central ulcer. So I think you should slightly modify the way you have described it. So say it is an irregular ulcer involving the majority in the inferior quadrant involving the central axis. It is this much size. And here, 7 to 9 o'clock position. One point you've missed, a very important point for a corneal ulcer is, did you measure the epithelial defect?
When the patient came to us, actually, patient had actually gone to another district hospital and then had come to us.
No. I'm saying as you examined, did you stain and see this patient?
No, madam.
So if you stain, which stain will you use?
Fluorescein.
Yeah, which other stains can you use for corneal staining?
Stain.
You can use rose Bengal stain also, but rose Bengal is usually used for viral ulcers. So fluorescent stain is what we usually use. So why you should stain and see any ulcer? I keep telling
Yes.
whatever students we get to teach in health service that you should always stain. So hello.
Hello. Had an epithelial defect.
So it stains epithelial. So rather, will the epithelial defect always conform with the infiltrate? Will the size of both of them be same?
No, madam. Infiltrate more larger size than the epithelial defect. The size of infiltrate will be more than the epithelial defect.
Always, is it?
If it is a fungal,
or rather,
if
it's just an indirect way of telling me. What are the stages of corneal ulcer?
Okay, first there is a stage of progression,
Yes.
then stage of active ulceration, then stage of regression, followed by stage of cicatrization.
Okay, so in the stage of progression, how will the ulcer look like?
In that stage is where the breach occurs and the organism enters, and that is when the
I'm not saying about all those things. Just how the ulcer will look like.
A grayish white in appearance, madam.
Okay, I will explain. So stage of progression is where you will have a large epithelial defect because the organisms are really multiplying. So it's eating away all the things. So the epithelium will be really big. And then you will have an infiltrate forming. So you'll have an infiltrate. There'll be a lot of discharge. There'll be a lot of redness. So it's a very shabby looking ulcer. That is what the stage of progression is. Say for where you have started treating and the organism has started responding. So that is a stage where there is a regression. In this case, specifically in the stage of regression, the entire the mechanism has helped in healing it. So the epithelial defect will become smaller size, the infiltrate will become more clear cut, and the surrounding cornea will all become clear. All symptoms of the patient will decrease. The density of the infiltrate will decrease.
Okay.
And finally, in the stage of healing stage, you will get vascularization, small vascularization, and the epithelial defect will start closing completely. It will start opacifying. This is how the healing stage occurs. So this is how you differentiate on the basis of looking at the ulcer, whether it's a progressive stage, a regressive stage, or it's a healing stage. So that is why measuring the epithelial defect is very important in your case, and you should not miss it. You should stain any ulcer that you say. So 2 questions to you in this case is, is there any ulcer that can present without an epithelial defect, or is there any organism that can penetrate an intact epithelium?
Yes, madam.
Yes, tell me, which are they?
Neisseria gonorrhea, Neisseria bacteris, bacteria, diphtheria, Haemophilus, and Listeria species.
And which?
Listeria, madam.
Okay, so you mean you missed out the most important one.
Bacteria, diphtheria, madam.
That is very common ulcer. It's a very common ulcer.
Neisseria.
Neisseria is a common ulcer.
No, madam. Um, correct.
Because pneumococcal also can penetrate intact epithelium.
Okay, madam.
Okay.
Okay.
So there is hemophilus. I remember as HDLN as hemophilus, diphtheria, listeria, there is Neisseria, and there is Streptococcus pneumonia. So pneumococci should be your first answer. Don't go and say all the rare species and then miss out the most common thing. Okay.
Okay.
So
Okay.
pneumococcal ulcers can penetrate intact skin. They're very virulent and dangerous ulcers because pneumococcal ulcers, they spread right under the epithelium. They'll go, they're like undermining ulcers. That's why they call as ulcus serpens. Because you will have it is an ulcer where the epithelial defect will be small, but the entire infiltrate will be right under there. It's like Titanic, the iceberg. Okay, you will see a small tip of the iceberg, but the entire big ulcer is right under the epithelial defect. There's a big ulcer, and it will it will easily perforate. Okay, so that is how a pneumococcal ulcer would be. Then, okay, so what are the signs of healing of corneal ulcer?
Okay. The signs that we have to see is the end blunting of the ends, then the density of the stromal infiltrate. Then
The density will decrease. Then
density will decrease. This the size. Then we have to see if there is any AC reaction. Then if that is reducing.
Okay, so if there was a hyperpoint, you should say the hyperpoint. Okay, you will expect the hyperpoint to decrease. Okay.
Madam, then.
So these should come to you like these are very commonly asked questions. So you should say it immediately. Symptoms will decrease, the signs will decrease. They also become small and more well-defined. The margins become well-defined. The infiltrate density decreases, density and the depth will decrease. The epithelial defect will start healing, and the satellite lesions will start healing. The hyperpine will decrease. The surrounding corneas starts clearing. It should come on tip of your hands. These answers, okay, when you're pressing a case of corneal ulcer.
Okay.
Okay, then you mentioned about corneal sensation. So which ulcer has a decreased corneal sensation?
Viral keratitis, madam.
Okay. You have mentioned about immune ring. So which ulcer has an immune ring?
Fungal, madam. Fungal ulcers.
Yeah, fungal has an immune ring, but usually a ring ulcer, a ring infiltrate and
madam.
Acanthamoeba ulcers causes ring infiltrate. In fungal, you have a name for the immune ring. It's called the immune ring of? Yeah, Wesley. It's called immune ring. And you look for pigmentation. Which are the pigmented ulcers?
The filamentous, which are non, the curvularia, bipolaris, all these cause pigmented corneal ulcers.
All filamentous cause pigmented ulcers?
No, not all filamentous. These two, that is the curvularia and bipolaris. I don't know.
Yeah, it's a pigmented. The pigmented filaments fungi causes these usually this thing, pigmented things. Then okay, so that is where you ask for pigmentation. So you were always thinking in terms of a fungal ulcer. Okay, then Van Herrick's grade, anterior chamber Van Herrick's grade 4, you have said. In the other eye, I liked it that you written there is no gut tape because I was specifically thought of asking you this question. Why you look for gut tape in the other eye?
Madam, any dystroph endothelial?
So you're presenting this as a case of a pseudophagus bullous keratopathy with a secondary ulceration. So you thought of the other eye looking for gut tape. So what are the other causes for pseudophagic bullous keratopathy?
Other causes of
What are the causes of pseudophagic bullous keratopathy?
Yeah, if there is a intraocular complications of like the instrument touches the endothelium.
That is iatrogenic, okay.
Iatrogenic. Then endothelial, madam, already if there is endothelial decompensate.
Like what?
Like fugues.
Yeah, any endothelial dystrophy, okay.
Like fugues, congenital hereditary endothelial dystrophy or anything.
Okay.
Then
what else?
Then
Yes.
Vitreous comes in.
Yes.
With the
So when
contact.
there is a when there the PC has been compromised and there's a vitreous, you see a vitreous strand or something in the vitreous itself can cause endothelial decompensation. Then the type of lens.
Placed that where it is placed, that also matters, like
Which one matters?
AC.
Yeah, and anterior chamber IOL. Then
IOL.
after that, more harmful, less harmful for then there's iris claw, and then the PCIL usually doesn't have any problems, isn't it? So if you are presenting a case like a pseudophakic bullous keratopathy, I think so you should have looked for any telltale signs for because you're saying the other eye does not have any gut teeth and there's no dystrophy, and thinking that like you are saying it is a pseudophakic bullous keratopathy, probably you should have thought like seeing for telltale signs of any bad surgery or a prolonged time for the surgery. So you should have looked for what all things, maybe some vitreous, some pigments on, you should look for pigments on back of the cornea, whether there is any DM tears or some things, DM opacifications anywhere. So those things are some of the things that you should look for. Okay.
Okay.
The next thing. And you have seen corneal sensation is normal. Please mention it that you have looked at the normal part of the cornea, because otherwise, if in an edematous cornea, the corneal sensation will not be normal. If it's a pseudophakic bullous keratopathy that has been there around for a long time, again, you will not be able to get corneal sensations normal.
Okay.
The next step. Okay, it's sad that you did not have any fundus view. Because okay, suppose I'm saying this is a case of you in the fundus you had a view and you can see a case of an old CR view.
Okay.
Does the entire clinical picture change? Would you still say this is pseudophakic bullous keratopathy?
No.
What other chance can it be?
NVI.
Yeah, you should look for an NVA.
Mm.
Okay, you should look for an NVA. I mean, though it is edematous, I think the superior part is quite clear. You should look for if there's any NVA over there. Okay, so you should look for that because an NVG could have happened and this cornea might have got edematous diffuse corneal edema, and that might have been the reason for her defective vision since 1 year. Okay, since 1 year. And that might be the reason because this PCI looks fairly good. And any picture
Okay.
Okay. And then the next slide, the diagnosis slide. We've written infective keratitis right eye. Why you see it is clinically fungal?
Then, madam, the picture, but when we were seeing it, it was more of a dry looking ulcer, madam, and it also had these feathery margins. So that is why it came.
Any points in against fungal?
Any points against satellite lesions for it? We didn't see any satellite. Just
so I would feel like it's such a big ulcer, isn't it? The ulcer is about 4 to 5 millimeters, and still you don't have a hypopyon. And also the duration of the ulcer is only 7 days or so. So within that duration, I don't know if such a big ulcer can come in fungal. So it looks more like a bacterial to me. And another thing is you have one of the risk factors, 2 or 3 risk factors staring at you, and you've not put them all in your diagnosis slide. Why?
Madam,
what are the other risk factors that you have? You have mebomitis. You have not put that. So you have mebomitis, you have ectropion, you have pseudophakic bullous keratopathy. All of these usually cause what type of ulcers?
Bacteria.
Yes, they cause bacterial ulcers. So I don't know whether your assessment on the basis of your clinical case.
No, madam, when this patient came to us, actually, patient had visited another hospital in Cambridge. So there, I didn't mention that because it was not something that we had recorded. Patient had a hypopyon. So patient was being treated like that. Then patient was referred to us. So when he came to us, we didn't have
this I think is nearly 1 hour. So can you quickly tell me how you manage this case?
Okay. Madam, first of all, after taking the every history taking and everything, there will be first a diffuse examination will be done, diffuse light examination, and then a slit lamp we'll stain it and see the epithelial defect. And
You've done all those things over here. No, you've reached the diagnosis.
Okay, and the
How will you manage?
Manage. Okay, I will start the patient on antifungals. The choice being 5% natamycin. And when after that I will see the severity. If it is too severe, I will start. I will also give a oral antifungal. Preferably go to ketoconazole 200 mg BD. And then even if then there is no improvement, then the next choice will be voriconazole 2%. After that, after that, there is no improvement. Then next will go intrastromal voriconazole or amphotericin injections.
So you are stuck on fungal on your clinical thing. So you're not going to do anything else. You're right away go and treat just fungal.
I also start the patient on fortified antibiotics because
why are you starting fortified antibiotics?
Bacterial infections, madam.
But you've already started a fungal, so why you would want to start a fortified? So again, because you're a very young kid, I think so. നമ്മൾ പണ്ട് പ്രസന്റ് ചെയ്യുമ്പോൾ നമ്മളോട് സ്ഥിരം പറയും മാനേജ് ചെയ്യാന്ന് പറഞ്ഞ് ചാടി കയറി ഈ ആന്റിബയോട്ടിക്സ് പറയല്ലേ എന്നൊരു 100 തവണ പറഞ്ഞു തന്നിരിക്കുന്നതുകൊണ്ട് വിൽ നെവർ ഫൊർഗെറ്റ് ഇറ്റ് ഇൻ ഹർ ലൈഫ് ടൈം. So as soon as you're asked how will you manage, the first thing you should say is that I will investigate this patient. And so since this is a corneal ulcer case, so the first thing should be that you should send for a scraping. So you should do the scraping. And again, scraping should be clearly mentioned how you should explain the patient, take the consent, and you should do the scraping. Means anesthetize with proparacaine and then take the scraping. And then instill in it what all things?
We do a gram stain, Gimsa stain. We'll use a 10%
gram stain.
Gram stain, Gimsa.
You do Gimsa stain at your place?
No, madam. That was theory. Sorry, I do a gram out here. We do gram staining, and then 10% KOH wet mount.
Yes.
And then calcoflower white.
That was you do, huh?
No, madam.
Don't say those things then.
Okay, only the gram stain and KOH. Then after that, we'll send for culture. Here we send blood agar, then chocolate agar, SDA, and then if non-nutrient agar with E. coli overlay, if it is also available for.
Yeah, if you're strongly suspicious of a candidate, it's not among the routine cultures, but if you're strongly suspicious, you can put it in SDA also. That is a usual routine. Okay, but as soon as that is over, then you start. If your clinical suspicion is fungal, then a first line of the drug of choice would be
Natamycin.
Natamycin. You will say 5 times, 5%. How many times?
Hourly one.
Yeah, hourly for the first
24 hours.
For first 48 hours is hourly.
Oh,
okay. For the first 48 hours is hourly. Then along with that, this is how you should say, you do the scraping, you send investigations, okay? That we missed out. Investigations. We have to send investigation because you're thinking this is fungal. So it's very important that you have to rule out the diabetics. You have to assess the diabetic status of this patient. So send minimum investigations, at least an RPS you should send, and a screening of this patient because you want to know whether this patient has got HIV or any immunocompromised states because again, it can cause non-healing ulcers, and then you go and start the drops. So either you start a fortified or you start an antifungal, depending upon your clinical suspicion. You don't put it all together because then your clinical assessment will not happen. So if you think this is fungal, then go and start natamycin. Okay. And along with that, so that we don't miss out any by chance a bacteria. We put what? We don't put fortified. What else can we put?
So
which is the monotherapy for bacteria that we use? What we use is fluoroquinolones, okay? You can use moxifloxacin. I think 0.3% something, okay? You have to use it. You put just 4 or 6 times, that's all. Don't put it hourly. Because your suspicious fungal and you should trust your clinical suspicion and start it accordingly. It might go wrong, it might come correct. That is why you have to, this patient is admitted and you have to see the next day and change it accordingly. So after 48 hours, what will you do?
If there is improvement, we'll continue. If there is no improvement, then I will do a repeat scraping.
Hey, why do you want to do a repeat scraping? Your scraping result has not yet come, no?
I'll repeat. I'll wait for 20. I'll stop the.
No, dear, you have sent culture in the first time. No, that report will come after 48 hours. So that you have to look at the culture report at 48 hours and see what organisms has come out. So if this ulcer has been, it has been responding to your present treatment, then probably you can add on any suggestions that is given by the culture report. But if the treatment is not responding, then treat according to the culture report. Whatever is the organism that you've got and the sensitivity you've got, start those drugs. And again, for the next 48 hours, you continue that for hourly if it's a new drug. Or if it's responding, now you decrease the drugs that you have already started to 2 hourly. Okay. So how long will you continue this? And definitely in your oral, if you think this ulcer is very big, you can start an oral antifungal. So my next question is, what is the indication for starting an oral antifungal?
Scleritis, there is limb involvement.
If it is a
if it is extends,
if it is a large ulcer, then it is a very dense ulcer, an abscess is there, or you have an endothelial plaque. There is a fungal ulcers can have endothelial plaques. You have an endothelial plaque, which the topical medications might not penetrate into that endothelial side. Or if you have a limbal involving ulcer, that's going to the limbus and it can go into the sclera. Or you feel that this ulcer is not responding that well, or you feel that there is a posterior segment involvement and an end of chances there, then you start a patient on oral antifungals. Okay. Okay, then how long will you treat an fungal ulcer?
If it's healing, we will continue the oral for 2 to 3 weeks.
After it's completely healed, you continue after 2 to 3 weeks. Okay. Then when you are using natamycin, is there anything else that you should help out when you're using natamycin?
It is a suspension, so we have to shake it well. Madam.
Okay, you are shaking well and then putting it. Still there is a white color thing. What will you do?
So it helps in the growth. I don't know if I'm right, madam, but it
okay, you should keep on scraping the surface, because natamycin does not have surface penetration, doesn't penetrate a normal epithelium. It cannot penetrate an intact epithelium. So, and it also forms a suspension. So you have to keep scraping the the plaque that forms on the surface so that the natamycin can penetrate well. So why are you using natamycin and not using any other antifungal? So what is that based on? There were some studies.
Mud study, madam?
Not mud study. Don't go to that. That's not mud study.
Which,
I mean, it's not a study. It's like on the basis of the different organisms that is found in Asia. What is the most common organism in Asia?
Aspergillus and Fusarium.
Okay.
And
among the
southern side, we have Fusarium.
Yeah, and which is most effective against these?
Natamycin.
Natamycin is most effective. So if natamycin is not working, will you directly go into voriconazole or will you try something else? Yeah, amphotericin B. But the only problem in amphotericin B is that you have to reconstitute it, and it's highly toxic to the conjunctiva. Okay, so that's the problem with amphotericin B. And then if suppose this was a candida ulcer, so then what will your drug of choice be?
Amphotericin or nystatin, madam. But amphotericin or nystatin.
Fluconazole.
Okay,
Okay,
fluconazole.
candidates, fluconazole. And then, of course, voriconazole. Okay, suppose this patient, I want to start voriconazole. I feel like voriconazole can be effective with kids, yeast, fusarium, and rhizopus. So I'll start voriconazole first. Will that be good? As my drug, first line of treatment, I'll start voriconazole.
No, madam. Then if it is not,
I think that is what MUT trial was about.
MUT trial was natamycin was better than.
Yes, that is what MUT trial was about. So the natamycin should be there. Voriconazole should not be used as a first line or a monotherapy. It should not be used as a monotherapy, and it should be used only as an add-on therapy to natamycin as a second line drug. Okay, so that is why that came out. The MUT trial came out. So there was a MUT trial 1 and a 2.
The 2 was that oral antifungal, oral ketoconazole did not have any effect.
Yeah. Didn't have much of a role. Oral antifungals did not have much of a role. So just related to this, there's another study called SCUT. What is that?
Oh, I don't know, madam.
That is a homework for you. Sir, sir, sir. Sir, go ahead. Sir. I think so. I think we cannot complete the discussion of fond ulcer in 1 hour like that, because there's an entirely bacterial and there's so much to discuss about it. I think so. If you have any doubts or we can.
Sir left, madam.
Okay, that's okay. Okay. I think so. Then we'll stop here.
Okay.
So how did you think? Did you have any doubts or something?
No, madam. I didn't know that pseudo, that I think that, like you said that they could penetrate, pseudomonas could penetrate an intact epithelium. So
no, pseudomonas does not penetrate an intact epithelium. I said
pneumococcus.
Okay, so you're a first year, so it's too much for you. The questions that I asked is what is asked for a MS candidate in final year. So for you, it is too much. So hopefully you will just keep this as a lesson and keep reading. When you read, you will find out the answers to most of the questions that I've asked you. So I think so. This is how you will be asked to present in a thing, and they'll see every point that you've asked in your history, everything they will ask you. Okay. So with that, we'll stop this then. Thank you so much.
Thank you.
Yeah,